You will not force.
Morning, and thank you for having me. This was my welcome to Oxford. Can you give a lecture on Friday morning speech? So yes, I can. I'm going to split it into two halves. The first part is a slightly more broad brush view of pre-hospital medicine in the UK, what's been happening in it in the last few years, some of the innovations in structure and function. But that's only going to take me about 10 or 15 minutes. And then I thought we'd move on to something a little bit different. We're going to talk about some of the approaches to a road accident, because I suspect, looking around the room, most of you drive, and there is always that slight fear, isn't there, of if you're driving down the road and that motorcyclist that whizzes past you at 90 mile ends up in a ditch, what are you going to do about it? So I thought we'd talk about a little bit about that towards the end. And if that leaves us with any time for questions, then you can stand up and abuse me. Dr. Black's here to do that already. So, who am I? Like I say, I'm Ross Moy. I'm an emergency medicine consultant in the British Army, which basically means we do the same training pathway as everybody else. But also, I've done a few other bits and pieces. I've worked up in Scotland doing retrieval medicine to the Highlands and Islands, worked on the air ambulance down here for a bit, and did a bit of work in Iraq and Afghanistan, which is kind of not too dissimilar, but a bit sunnier, a bit hotter, and a lot more flies. So, it's early in the morning. I don't know about anybody else, but I'm one coffee down and still struggling. So here's my take-home messages right at the start. Okay, this is pre-hospital medicine in a nutshell. If you want me to cut it down even more than that, air goes in and out, blood goes round and round. That's pretty much it. As long as that's working, you're doing a good job. And the last bit, despite what the press would have you believe, and the Helicopter Heroes television, it's not all about the helicopter, except when it is, and I'll talk about that at the end. Okay, so here's the first part. We'll talk a little bit about pre-hospital emergency medicine, what it's doing. I did say it's not about the helicopter, but you still have to have some helicopter thoughts, don't you? How it's staffed currently, and where we get those staff from, and some of the changes in clinical capability, because we've come a long way from a chap with an ambulance, a stretcher and a bandage. In the UK, that's a map of the UK with all the HEMS bases dotted around the country. Not entirely. Some of them are, these are the paediatric ones, and the green ones are the adult ones. There's a big gap you can see there, which is currently being worked on. They are predominantly, certainly in England, they're charities. They're not state-funded. They're all raise funds from the local area. And generally the aircraft and the pilots are run by the charities, the doctors usually by the charities. The rest of it depends. Every charity's got a different relationship with its own local ambulance service. So here we've got a very close relationship with the South Central Ambulance Service. It works very well both ways. Our paramedics are South Central Ambulance Service employees. They are still owned by the ambulance service, and the ambulance service are very good at helping us with some of our equipment. The charity buy a lot of the capital stuff, the big expensive toys, but the everyday stuff, the boring old stuff that just keeps us going, a lot of that comes from the ambulance service. So we've got a very close relationship with them. Other services, some others I've worked with, have a slightly more hands-off approach, and they very much see themselves as separate entities who work with the ambulance service rather than for them. If you go to Scotland, there's an interesting mix up there. So there's a charity air ambulance that sits just outside Dundee, and then there's a state-funded ones in Glasgow and Inverness. This is search and rescue up here in Aberdeen. Similarly in Wales, there's 3 air ambulance bases in Wales, and they're all state-funded. The difference in these countries is it's a matter of geography. When you've got poor roads, very rural areas, and you can see this huge area, very sparse population, ambulance response times are very long, and so there's much more of a need to use the aircraft to project your medical capability further and move people further. So, that's that. When I said it's not all about the helicopter, what we generally find is, especially down here, where population density is much greater, and the whole point of the aircraft really is not necessarily about flying patients as much as it is flying the team. The big thing about the helicopter is it allows a HEMS, or Helicopter Emergency Medical Service team, to cover a much wider area than you would just by car. Particularly, for example, in London, as you can imagine, the distances are very short, but what you have in London is traffic, and the helicopter allows you to pop over that. So, that's that. Quick little word about search and rescue, because there's often a lot of confusion about where it ends. Search and rescue has recently changed. Started off in the 1940s as a way to rescue downed pilots in the Channel, and it's been a Ministry of Defence responsibility from then until now. So split between the Royal Air Force and the Royal Navy, predominantly sea-focused. I found out quite recently that our search and rescue area of responsibility, I always thought it was just around the UK. It's not. It finishes somewhere in the middle of the Atlantic, and that is all the responsibility. Used to be the responsibility of the Royal Navy. That's now been taken over by the HM Coast Guard and the Venerable Sea Kings, which I'm really quite fond of. They're a lovely aircraft, although they're described when I first started flying on them as a bit agricultural. Have been replaced by very swish and shiny Sikorsky S-92s. Search and rescue is not a pre-hospital emergency medicine platform. It is not HEMS with a winch. Their job is very different. Their job is much more about finding the injured casualty and moving them. There's been some really good work done by a lady called Linda Dykes in North Wales, looking at the kind of patients that search and rescue see. If you'll forgive she puts it a little more colourfully, but we generally find that for the search and rescue guys, if you fall off a mountain, you're either okay or you're dead. Like I say, she puts it a little more colourfully, but I think you get the idea. Our staffing is these days looking much more towards a doctor-paramedic model. Some of the air ambulances, Yorkshire, I think, and the North West still run predominantly a dual paramedic model, but they are moving towards a physician-paramedic model. That's probably the way of the future. We complement each other very nicely. I love working with paramedics because they're really good at all the things I'm rubbish at, like staying safe and keeping out of trouble, keeping the kit organised. They keep me right brilliantly. Used to be predominantly pre-hospital emergency medicine was the preserve of people who were just interested. Again, historically, it's generally been general practitioners providing an enhanced service to their local areas. And that's worked very well, but there are certain expectations of modern pre-hospital medicine, particularly more of the critical care aspects, that are just very difficult to meet from a general practitioner point of view. And the other change we've had is that paramedics recently have vastly increased their skills set from the ambulance drivers that you see on Call the Midwife. They're not, they're very, very, very different from that now. They are pre-hospital clinicians. So we had to work out a proper formal training pathway for our pre-hospital doctors, and that involves a GMC accredited subspecialty training, so you can have a CCT in your base specialty and emergency medicine, predominantly emergency medicine and anaesthesia, although there is a capability for intensive care medicine and acute physicians. There's one acute physician in Cambridge and a few intensivists kicking around. GPs, still not quite formalised. There's still a lot of GPs very active in pre-hospital care, and a lot of them do a very good job. But what we're finding is that GP training at the moment doesn't really have as much exposure to the critical care side of it. And GPs now who are wanting to start doing pre-hospital medicine are having to go back and do a 2-year programme to expose them to emergency medicine, anaesthesia and the critical care side of work. So it's a year's training in addition to your base specialty. There's different models used all over the UK. Some people will do it as a full-time block. They'll just spend a year doing nothing but pre-hospital emergency medicine. Around here we do it as a blended training pathway, so our trainees do 2 weeks on, 2 weeks off. For preference, I think that works very nicely because, particularly in the winter time when the weather's bad and the motorcyclists stay at home, HEMS can be pretty quiet, and it's very easy to get a little bit bored, a little bit stale. So a little bit of keeping in touch with your base specialty is always a good idea. So we've got our team. How do we get them to where we need them to be? This is the thorn in the side of pre-hospital medicine. It has been, as long as I've been involved in it, and I suspect those who have been involved in it a lot longer than I have will say that goes back a lot further. The difficulty is you've got a limited number of advanced assets and a lot of area to cover. How do you make sure that you're getting to all the patients who are going to benefit from advanced interventions and that you're not delaying patients getting to definitive care? There's various models have been tried around the country. Some ambulance services rely on the ambulance service dispatcher, who are non-clinicians, and they will decide based on what the caller tells them whether or not it's appropriate to dispatch a helicopter or an advanced pre-hospital team. Some places, the Great North Air Ambulance would be a classic example of this, have a paramedic that basically sits in their, they sit in their base all day watching the ambulance call screen, and they'll decide themselves when to dispatch. What some places, and this is our model, and I personally, of course I'm biased, but I think it's the superior one, has a clinician. This is the model we use in the military, and it's the model we use in Thames Valley. We'll have a clinician who sits in ambulance control, who can watch, there's an oversight of a bigger region, can watch a whole area, all the jobs that are coming in they can see, And they've got two capabilities. First of all, they can put a clinical eye on what a caller tells them, because if you've ever worked in an ambulance control station, you'll see that what the public tell you about an accident is often very different to what a clinician will see. And our paramedics are very good at teasing out that information so that they can decide when there's somebody who is going to benefit from extra interventions. And they will also ring callers back and say, when you said they were unconscious, what exactly did you mean? And again, different people have got very different ideas of what that means. So that, we find that provides us with a really good mix of making sure we get to all the people we need to, but tries to avoid us going to people who either don't need what we've got to offer or in whom we're just going to delay things. Major trauma networks, I know that doesn't project very well, but major trauma networks are where we're all working now. Certainly in England, it's coming in Scotland as well. We find that one of the most difficult parts for this is triage. Primary triage to a major trauma centre is a real thing. This is the paramedics tool, but it's used by all of us really. But there are issues with it, and there's a real problem with particularly over triage. The classic is the drunk head injury with the GCS of 13. Now that's probably partly because he's had a wallop to the head and partly because he's had a skin full of booze. And it's very difficult sometimes to tease that out. And one of the things we find is that having advanced clinicians with the capability of going to scene allows us two things. It prevents that over triage, but it also gives us the ability to look at patients and go, yes, I know you don't quite fit into this trauma tool, but I know because of your mechanism and because of where I predict your clinical course to be, you may need to go past. The other thing we can do is decide that actually this patient's too sick to go to a major trauma centre. There are issues in terms of flying patients. Geography allows us to get there quickly by helicopter, but when we get there, there's often a decision to be made there about whether or not flying is the right thing. For those of you who've not seen our air ambulance, it's actually a lot smaller than you think. And moving patients in that confined space with very limited access to the patient has its own risks. Sometimes flying patients forces you to do things that you wouldn't necessarily want to do clinically just to make them safe to go in the aircraft. So a lot of the time we'll decide to get there by aircraft and move by road from there. But again, that sort of decision making is what we can bring from our advanced pre-hospital teams. So, some of the things we do in terms of equipment and innovation. I'll be honest, CPR, despite the ALS courses that will teach you, there's actually very little evidence for many interventions that we do in cardiac arrests. But there is reasonably good evidence that good quality CPR consistently given does lead to better outcomes. People do, and that's, people do leave hospital and go on with a normal life more if they have good CPR. What we will carry now is an automatic CPR device. They're usually electric. Some of the ones you see in hospital are gas-driven, but ours are usually battery-powered. And that allows us to give a greater consistency of CPR. People don't, machines don't get tired, they don't get bored, they don't get distracted. And it frees up our team to do other, potentially more useful interventions. So we do that. Intraosseous access, it's been going for a long time in children, but this is something that I wouldn't say we pioneered it in the military because it's been used in other places, but we've definitely brought it into commonplace practice. And we can do an awful lot through an intraosseous needle. Again, used to be a paediatric intervention, but now we've found that you can do a full resuscitation through intraosseous needle. It hurts the patients quite a lot. I wouldn't suggest you try to do it too much with people who are awake. But you can give an anaesthetic through an IO needle quite happily, and it works very well, particularly when you use the humeral head. It drains very nicely into the central circulation. Ultrasound has the potential to be a real game changer for us. We can't carry radiology equipment. I'm just having this image now of a radiographer trying to set up a cartridge next to a car crash. It's not going to happen. But ultrasound has moved out of radiology very much into the emergency department. It's now a core skill for us. But we've also started to carry it forward. For example, we can use it for detection of pneumothorax. And it's in some ways actually more sensitive than chest x-ray if it's in skilled hands. But also as a rule-in tool, we can do focused abdominal sonography looking for free fluid in the abdomen, which is a rule-in test and can tell us whether the patient's got bleeding. That's very useful when it comes to handing over a patient to a general surgeon to say, actually, I know that this patient's unstable, I know that they've got blood in their belly, we're going to need to do something surgical about it. We can also use it for imaging the heart. One of the interventions I'll talk about later on is the use of a pre-hospital thoracotomy for penetrating cardiac injury. Again, we can use ultrasound to directly visualise the heart. We can see whether it's beating, whether it's fibrillating, whether it's beating in an organised fashion, but we can also see whether or not there is a cardiac tamponade that we might be able to drain by doing an open thoracotomy. In the future, as people get better, I have to confess this is beyond my skill, but people can use it for diagnosis of fractures. So you may find that certainly in remote rural locations, this negates the need, or doesn't negate, but reduces the need for radiology. And that's something we're looking at very closely in the military, the ability to project that forward in a way that's very hard to do with X-ray equipment, both because it's big and bulky and because there's the risk of exposing people to radiation. Some of our other capabilities then. We are moving towards using new resuscitation techniques. We're keen on balanced resuscitation. So where previously the guidance was to give cold, salty water, I think we've finally caught up with the fact that that's generally bad for people. Excuse me. Most services now will carry packed red cells and will be able to resuscitate people with blood products. But even then, that's got issues itself. I mean, packed red cells are not a particular physiological fluid. They're fairly acidic, they're full of citrate, and they take your calcium away. So our resuscitation technique is based on two things. First of all, arrest of hemorrhage as quickly as possible. So exsanguinating hemorrhage, and we've gone back to the, tourniquets have gone in and come back and come out and gone out. They were used in Roman times, and we've finally come back to the decision that they are a good thing in certain patients, and significant limb bleeding, they are definitely life-saving. So the first point is always to stop the bleeding and turn off the tap. For non-compressible hemorrhage, we can use things like pelvic binders to splint pelvic fractures. We can splint long bone fractures as well, and again, reduce the space in which people can bleed. Then we can resuscitate them with an oxygen-carrying fluid. We would also change, again, instead of looking for normal physiology, particularly in patients who've got truncal injuries and penetrating trauma, we would aim just for just enough circulation to maintain central perfusion to the brain and the vital organs so that we can move the patient fast. And these are the patients who a surgeon is really what we need. We can do some things, but really where they need to be is in an operating theatre, having their hemorrhage stopped. In addition to packed red cells, there's been some work recently looking at carrying fresh frozen plasma, which basically gives us the ability to carry clotting factors to the patient. Some services are using freeze-dried plasma that's reconstituted. In Thames Valley, we've recently started carrying defrosted fresh frozen plasma. I don't know how we got that past the blood bank, but I think it's a brilliant thing to be doing. But the evidence is light. We've got some evidence for balanced resuscitation and trauma in the emergency departments and in theatre. Whether there is benefit in carrying these things forward, we're still looking at. And there is a trial ongoing by some guys in Birmingham looking at that, trying to decide whether or not it does help. Tranexamic acid, the CRASH 2 study shows that in bleeding trauma patients it does improve survival. And if it's given within the first hour is when it's useful. So if you've spent 45 minutes of that first hour trapped upside down in a ditch, the earlier you get it, I would suggest the better. I can't quite back that up with evidence, but I think it seems like a reasonable thing to me. So again, we can carry tranexamic acid forward and hopefully use it to stop people bleeding. Anaesthesia pre-hospital is still, I would say it's less controversial than it was, but there are still some people who say you shouldn't really be messing about doing that. I get that point, but I think there are definitely still some patients in whom an anaesthetic pre-hospital is both the right and the safe thing to do. I mean, our indications, the non-controversial ones, if you have an unmanageable airway, securing it is, an essential thing. But also prevention of secondary brain injury by control of ventilation. Again, there is evidence of that helping people. Ventilatory support, again, significant chest injuries, very difficult to self-ventilate if you've got two pneumothoraces. Putting in chest drains forward of hospital is very difficult, but it's a lot easier to provide positive pressure ventilation and then decompress the chest, and that will temporise those injuries enough to get them to surgical management. And the other thing that is quite useful, that anaesthesia is very useful, some of the things we do to people are extraordinarily painful. I mentioned intraosseous resuscitation. Giving more than a few mils of fluid straight into a marrow cavity hurts an awful lot. In a shocked patient, that may be what you need to do, but as they begin to fill up and become better cerebrally perfused, what you're doing to them is fairly inhumane, and giving them an anaesthetic is often the only way to control that. Similarly, when we're dealing with some of our combat casualties, if you've stood on a large landmine and lost both your legs, generally there's a high risk of significant pelvic injury, pelvic and perineal injuries, and often to pack and bind an unstable pelvis is extremely painful, and an anaesthetic is the only way safely to do that. The recent NICE guidelines on major trauma advise that an anaesthetic capability should be provided within 45 minutes of injury. And again, the only realistic way to provide that in a lot of places is for an advanced pre-hospital team to move forward and provide that before transfer into hospital. In terms of Revision of thoracotomy, again, this has gone in and out of favour. The Americans will do it on anybody. It's just crazy sometimes. But I think we're fairly close to honing down the patients who tend to benefit from open cardiac intervention. And it's generally low velocity penetrating injuries, generally stab wounds to the centre of the chest. The patients who do well are the ones in whom you find a cardiac tamponade, you open the chest, drain the tamponade, and you can fill them up again, and the heart starts to beat again, and the patients can do very well. There is an anecdote kicking around the streets of London about some chaps who were in the middle of doing a thoracotomy and a young man who'd been stabbed before they realised that he already had a clamshell scar, and he was in fact a repeat offender. He was on his second, and sadly it didn't end as well the second time as the first. So. Traumatic cardiac arrest. This is, again, an area of significant change. The European Research Council have recently changed their guidelines to take account of some new work that's been done in this area to say that actually maybe jumping up and down on an empty heart is unlikely to improve outcome, and that we should focus more on interventions that we can reverse pathology. So decompressing the chest, blood product resuscitation, control of massive hemorrhage. These are things that are much more likely to affect our survival rates. And you can see there are some people who say that the survival rates in traumatic cardiac arrest are so low as to not be worth trying. I would disagree there. I think there are some patients in whom some of these interventions can make a significant difference, and I'd say I've seen it. So, where are we going in the future? The guys in London are very keen on resuscitative endovascular balloon occlusion, so passing a catheter in through the femoral artery to help control distal bleeding, and then you inflate a balloon in the distal segment of the descending aorta, and again that can stop bleeding in pelvic injuries and intra-abdominal injuries. It's still very much in the trial phase. Whether it becomes the way forward, and there's lots of things to get past before it does, we will see. Use of blood products. I've talked about the use of fresh frozen plasma, balanced resuscitation pre-hospital, but again, we're not sure whether that is really, if that's something we should be doing pre-hospital, or whether we should be moving towards just more rapid transfer. And other blood products, potentially, again, we found in Afghanistan that giving balanced blood product resuscitation is good, but we need to balance that against where we are and our patients' need for proper definitive management of their injuries. Paramedics, I mentioned that we've come a long way from the 1970s ambulance driver, but there's a long way still to come. We're finding paramedics now are expanding their skills, and we're not really sure where that's going to end. Whether they're going to, well, they might do me out of a job. I'm not entirely sure. We'll see. Another, nurse, when working doing retrieval in Scotland, a lot of our advanced practitioners come from a nursing background. Again, nursing and pre-hospital care is something that's in the civilian world is still trying to find its place, but I don't doubt that there is a place for it, and we'll see that hopefully in years. Something else that's probably worth touching on is the fact that we can do more than trauma. I mean, this is a world that tends to attract trauma junkies, and that's all very well. Thames Valley Air Ambulance provide a critical care car where we will go to medical patients at home, and we can do a few things. We can start interventions for sick medical patients quicker, but we can also triage them more appropriately to an appropriate hospital for their needs, be it neurological, be it cardiac, whatever it is they have. We can also make decisions about whether patients can avoid transfer to hospital, and again, that saves significant money, saves significant time, and it's also just quite nice for the patients. If you're 75 and you can avoid a trip to hospital if you can avoid a trip to A&E on a Friday, well, anyone should avoid a trip to A&E on a Friday night, trust me on this, but it's still a good thing if we can make it work safely. Other things in our major trauma networks, some patients are still going to trauma units because patients will do a sensible thing to do, as I would suggest. If they have an injured patient, particularly a child, they will go to an A&E department. They may not know whether that unit has the specific specialist services they need. So there is a requirement for a secondary transfer service to move patients to where they're going to get their definitive management. Traditionally, that's been done from the trauma units by the anaesthetic team, but that has issues. A lot of times, it's a junior anaesthetist without specific training in transfer medicine, and it also strips that hospital of an anaesthetist, which is a bit of a consideration in a small hospital if you've only got one anaesthetic reg on call. So, using your pre-hospital team to provide that transfer service, who are used to working outside of hospital, are comfortable in the environment and familiar with the kit, has some potential advantages. So, that's that. How am I going for time? Okay. So, trundle through this just to give you an illustration of some of the things that we can do and some of the differences we can make. So this is a young man I went to in Afghanistan who stood on a landmine and lost both his legs. big pelvic fracture, and we put him on a Chinook. Now, our military pre-hospital teams are a little bit different. We use a team of 4, consultant, or actually was a senior registrar at the time, and we work on the aircraft, and the idea is that we provide resuscitation in flight rather than on the scene, because, as you can imagine, sitting around the middle of the desert with hot lead flying past your head is, I gather, quite it's not my thing at all. I'd rather be somewhere else. So we do it in flight. So in that 9 minutes, there's a list there of the things that we managed to achieve. I only show this as an illustration of what you can achieve in a short space of time when you've got a dedicated team and who train and drill and work at it. So that's fine. You don't get an awful lot of IEDs in Oxford, so I'm not going to dwell too much on the military side of it. But for a second here, we have rural location, South Oxfordshire, traditional young male motorcyclist, and hit a car at a junction. When that comes to the ambulance service, it comes as unconscious and breathing, but the nearest crew may be a technician who doesn't have necessarily a paramedic's advanced skills, and an emergency care assistant whose job is to really provide the driving and assistant to the technician. But a HEMS team can note the call, ring the caller back and say, well, when you say he's unconscious, what exactly do you mean? And that can provide a lot of information. So the HEMS desk, that paramedic can say, yep, that's an appropriate patient. So 25 minutes later, the HEMS team can arrive and find this patient. So agitated with a head injury, GCS of 10, a bit tachycardic and a deformed left femur. You're 20 minutes drive to the nearest hospital, and that, in days of yore, that's where you would have gone. But if you're 45 minutes and then traffic to the MTC by road, we can cut that time down by using the aircraft. But if those times were different, for example, if it was only a 10-minute flight, we might say, do you know what, it's easier to just go by road. But the advanced team would still go with the patient in the back of the ambulance. So that's what was done. Anaesthetic, femur reduced, pelvic binder applied, tranexamic acid, and a bit of fluid resuscitation on the way. So, there's probably more we could have done, but that's, excuse me, the idea is to do what you need to do safely to get the patient to definitive care. And then once he comes into A&E, because he's already anaesthetised and well packaged, he can have a primary survey in the emergency department, go straight to the CT scanner, and then move to, his injuries can be found, move to theatre, extradural, and then orthopaedics can sort the rest out the next day. And, remember that the key thing here is this is a very long process. People get very excited about the sexy first 24 hours where people are cutting and sticking tubes and things. But for the patient, this is the beginning of a long, long process. It's all about rehabilitation. And rehabilitation starts the second you're injured. And all of our work is about making sure that the rehabilitation happens as soon and as efficiently as possible. So that's where I have on our current structure. So that's there. I thought it might be useful because I suspect most of the audience, apart from Dr. Black, are not specialists in pre-hospital care. So it might be worth going through some things to think about as you're driving around the countryside of what you might do if you come across an injured patient. This comes with a fairly healthy warning that this is the world according to Ross, and these are my thoughts and my ideas. So, some preparations for your kit, things you can have in your car, things you can think about for yourself, how you can approach an incident and assess it. Very brief look at patient priorities and how you can then hand over to the paramedics and extricate yourself with a bit of grace and feel that you've go on your way, give yourself a cup of tea and a pat on the back and feel like you've done a good job. But then at the end of that, there's also the need to look after yourself because this is not a nice world to work in sometimes. So, first things first, in law, do you have to stop? In the UK, the answer is no. There is no legal requirement for you to stop and give assistance at an accident. Be careful, though, because if you go to France, and this is where some of the photographers who were involved in Princess Diana's sad death found themselves, unfortunately, on the wrong end of French law. If you don't stop and give assistance, then you can be done. General Medical Council will take this is the General Medical Council's guidance, and say you must offer anyone at risk the assistance you could reasonably, I think reasonably is the key word there. And I did ring my medical defence union and say, so what about all this? And they said no, they would consider that a Good Samaritan Act and would indemnify anyone against an issue. And I had a little look around. I don't know if there's a lawyer in the audience who can correct me, but as far as I know, there has never been anybody who's successfully been sued in the United Kingdom as a result of a Good Samaritan Act. So you can take some comfort in that. My kit list for the car. This is what I would suggest pretty much everyone should have in the car. A pair of rubber gloves, pocket mask to give some ventilatory support, and a foil blanket to keep the patient warm. Total cost, maybe a tenner. And all of that protects you and potentially can be very good for a patient. If you want some more PPE, some protection equipment, thick pair of gardening gloves, decent pair of boots, high-vis jacket, eye protection is really useful as well when there's broken glass and bits of stone flying around. If you want to carry some more medical kit, less is more is the answer to all of this. Remember, the air goes in and out, blood goes round and round bit. So some basic airway adjuncts, there's no point carrying intubation kit unless you carry drugs and a ventilator and all of that good stuff that goes with it. So I wouldn't bother carrying tubes and laryngoscopes. Pocket mask, and if you're keen, a bag valve mask might be very useful though. And then in terms of circulatory stuff, again, there's no point carrying IV access kit unless you're carrying drugs. So again, there's probably not much point carrying that, but a good set of pressure dressings could be very useful. There's not much you're going to be able to do in terms of analgesia unless you're carrying drugs. But keeping patients warm, and again, this comes back to there is good evidence that trauma patients, first of all, they get cold, and when they get cold, they get worse outcomes because hypothermia gives you coagulopathy, gives you acidosis, and once that sets in, it's harder to correct. So the warmer you can keep your trauma patient, generally the better they will do. So, we love our cliches in the military, so put that in. Okay, there's loads of training out there, and I don't know, just as a rough show, did anyone actually get any first aid training at medical school? Yeah, a couple of hands. We did some CPR, which is great, but actually in terms of how you manage injuries, it's not something that's generally taught at medical school. Unless you happen to have worked with an ambulance service, they often don't show you this stuff. And there's loads of first person on scene, first aid at work courses. The interesting thing I find is I am not allowed to consider myself a first aider because I have not done the health and safety approved first aid at work course, which I found out doing some scout work a few years ago, which I thought was quite amusing. If you're interested, there are more specific courses out there. The British Association of Immediate Care Specialists run a really good course down in Cambridge, which is 2 days. So you stay in a very nice hotel, and can do some more specific training. The other thing that's useful thinking about, as well as training, is this concept of conceptualization. We're very into simulation training in medicine now, but the best, most effective simulator we all have is inside your brain. So it's worth just devoting a little bit of time to think about what you would do as you're driving down the road, idly, listening to your podcast, about, as you will drive past the school, what would you do if a small child ran out in front of the road in front of you? Just worth having a little think about it. Again, I talked about the motorcyclist going past you 80 miles an hour. What are you going to do if you see him in a ditch? And the answer is not drive past laughing. Okay. If you approach an accident, this differs slightly from what the professionals are taught. The most important thing is approaching it safely. Okay, your safety as a bystander rescuer, your safety is the most important thing here. What's happened to them has happened. You didn't do it, but you can't really do an awful lot if you become a casualty, and roads are still very dangerous places. So the first thing to think about is a safe place to park. You don't have a jam sandwich covered in fluorescent kit. You don't have blue lights. Drive past the accident, stop, put your hazards on. And now is a good time to ring for a friend as well. When you're parking, that's a good time to be ringing somebody and saying, I need some help. Because the sooner you start that process, the better. If you've got PPE, get it on. And then, this is a point where you haven't really got a lot of time for thinking and cogitation, but you do need assess the scene, communicate effectively, and then try and provide some triage and basic treatment for the patients. So, this is what the ambulance service, in the first few minutes, need to know. They want to know how many patients you've got, how sick they are, and if there's any specific issues with those patients. That can be thrown as wide as you like. We like to know if there's children, particularly, because everyone gets a bit twitched about kids. And then when you're communicating, you have to think about which emergency service. Because if you ring 999, what's the first thing they ask you? What service? Well, do you know which service you can't just sort of go gibber down the phone, all of them! So, die Polizei, they're generally the command and control guys, okay? The police will have primacy of investigation and safety at the scene. Their job is to secure the outside of it, make it safe for people to work within it. They also have duties in terms of protecting the public and preserving of evidence. They also will try and preserve, if it's a road traffic accident, they'll also be looking to try and preserve traffic flow. I remember stopping at the Thames job on the M25, and as we lifted off just at dusk, and you could see the long lights going left and right as we had to close both lanes of the M25. It's an interesting feeling of power, but it costs £1 million a minute, so I'm not sure you should do that too much. And the police are quite keen to get traffic moving safely as soon as possible. Fire and Rescue Service, they look inwards. Their job is safety of the people within the accident. So their job is to secure the scene, safely extricate the patients. They will provide specialist rescue teams for entrapped patients, and if you've ever seen these guys work, it's phenomenal. They can have a car cut to pieces faster than I can open a tin of tuna. They're also very good at dealing with other environmental hazards, so be that cold, wet, heat, and the contents of vehicles. You know, if the smash involves a tanker, then that's potentially a risk to everybody. The fire brigade will deal with that. The other thing the fire brigade are great for is later on, when things are a bit more controlled, is they're a great source of disciplined and useful manpower. They're really good at just doing stuff. And then the ambulance service. What do we do? Triage, treatment and transport. Nice and simple. We look after the patients. Specialist medical services like HEMS or the hazardous area response teams, again, they all fall within the purview of the ambulance service. I'm not going to go into massive depth about patient management here. Okay, this is more about how we approach the whole thing. Our priorities are, first of all, exsanguinating bleeding. That's generally the first thing that's going to kill you. So if there's massive arterial bleeding, direct pressure, tourniquets if necessary. Airway, it's just simple airway management. Manoeuvres, adjuncts if you've got them. You're unlikely to have oxygen, you're unlikely to have advanced airway kit. Similarly, in terms of respiratory support, unless you've got a bag valve mask, and to be honest, if you're needing that, the patient's pretty poorly. But you might be able to decompress a tension pneumothorax, and that's a potentially life-saving intervention there. Again, circulatory-wise, control of hemorrhage, keeping them warm, really, really important. In terms of pain management, you might have some, if you don't have any medication, but there's still things you can do in terms of splintage, in terms of reassurance. You know, the Napoleon had a saying that the spiritual is the physical as 3 is to 1. And just the reassurance of having someone around who's saying, it's all right, we're taking care of you. I'm a doctor, I know what I'm doing, even if you don't. That helps people a lot. And the plea for me is, think about the environment. Trauma patients get cold very quickly, even on hot days. We would regularly load patients into an aircraft in external temperatures of 50 degrees, and they would still be shivering and freezing cold because hemorrhage makes you cold. So the foil blanket that I mentioned is a potentially life-saving thing. This always comes up about whether or not we need to immobilise absolutely everybody who's fallen over in Tesco's car park. And you end up in these ridiculous situations where someone's bumped their car into a tree at 3 miles an hour and decided that because they've got a bit of neck pain, the car needs to be cut up. It doesn't. Cervical collars are there, they have a place, and they are useful, particularly when they're properly applied. But they're overused, and their risks are not as well acknowledged as their limited benefits. If the patient is uninjured and is able to get out of the car, the current faculty of pre-hospital care guidelines, which I agree with, are if the patient can get out, let them get out. We used to do these ridiculous things where people would be walking around for 10 minutes and then an ambulance would arrive on scene, tell everyone to freeze wherever they are like musical statues, and they put a extrication board behind them, then drop them onto the back and carry them into hospital like that. Ludicrous. Why? If you've broken your arm, are you going to wave it around? What's the first thing you do with a broken arm? You hold it into yourself. Similarly, if you've got a broken neck, if you're awake and conscious, you're not going to wave your head around. You protect it yourself. So let patients look after themselves. If the patient can get out of the car, encourage them to do so. It's safer and it helps move them more efficiently onwards to hospital, because it's a lot easier to move someone who can sit in a chair than someone who has to go on a stretcher, particularly if you're dealing with particularly if you're doing more than a couple of casualties. I went to a job in west of Scotland where a coach had rolled over and we had about 55 patients. And one of the most useful things we could do in terms of clearing people was to get all these people off backboards and sit them up so that they can go in a minibus rather than using a fleet of ambulances to move them. So, when paramedics arrive, it's nice to have a structured form of handover. This is a kind of reasonably standard format, the ATMIST. So how old they are, rough time of incident, mechanism hopefully is fairly obvious. If there's cars upside down, it's pretty obvious what's happened, but still. Any injuries you found or you suspect, any signs and symptoms you've been able to give, and any treatments you've been able to institute. I would just finish it with a one-line summary. This is Maisie, she's been in a car crash, I think she's fine, but she needs a check. That'll do. Okay, how to get away. There will come a point where your work is done. The paramedics know what they're doing. They specialise in this, they do it all the time. You don't have to stand over their shoulders. It's not unreasonable to say, do you know what, I'm handing over to you, are you happy? Can I go? And they'll usually say, yeah, thanks very much, you can get on with your day. But you still have a duty to hand over the information you've got and help as much as is practical until there's sufficient people around. Because remember, the first responder may well be a fire service first responder, he may well be a technician, he may not be as comfortable, and he may get a bit of moral support from having you there. So feel free to extricate yourself, but do make sure that you're not needed before you do. Right, I thought I'd just put this a little bit. I'm trying to avoid talking too much about helicopters, but if there's a helicopter landing near you, this bit is worth knowing, particularly when we fly at night. Don't worry about finding us a landing site, we'll do that ourselves. The pilots do it from the air. It needs to be about 2 tennis courts in size. That's what they'll land on. If it's at night, please don't shine any lights because the crew will almost certainly be using night vision equipment and you can really dazzle them. If you shine any lights around the place, just let them work. The aircraft carries, it's like the surface of the sun underneath it to light the landing site, so you don't need to help. Just keep clear. A landing helicopter produces a phenomenal downdraft of air, particularly, I mean, military helicopters will knock you over, but even a small civilian one will provide a lot of wind. Just stay clear of it. As long as the rotors are moving, they're not our friends, so just stay clear of them. Stay clear of the aircraft until the rotors stop turning, and then after that, just go with what the crew tell you. Okay, I'm heading towards the end. It's not nice seeing people who've suffered significant trauma, even for people who see it a lot. But even if you're used to seeing it in hospital, remember that it will affect you very differently if you see it on the drive into work. It's not your environment, and if you're not comfortable in that environment, things may affect you more significantly. There's no rules about who gets affected or what affects people. And it's funny how it's little things, often smells, that get people. But, if your best friend drives that car or your brother has that motorbike helmet, these are things that can trigger memories in people. Being in danger yourself. If you come across a big smash on a motorway and traffic's moving past you at speed, it's not very nice. There's no rhyme, no reason to who has a reaction to this. It's quite normal to feel a bit shaken and a bit upset after being involved in something like this. And that, for most people, goes away, but sometimes it doesn't. It's quite, I wouldn't say it's unreasonable to go, I've had a hell of a day, I'm going to go home and have a drink. But if that drink arrives in another drink and another drink, or you're not sleeping, that's when things are a bit of a problem. There's an awful lot of people out there who are prepared to help, but you have to ask for it. And we as doctors are generally pretty crap at doing that. Be it friends, be it colleagues, be it your GP, be it professional, whatever. These people are out there. Don't be afraid to use them. Know yourself and know when you're not all right. So, this is my last slide, so we can carry on with our morning. The challenge is, a fair number of you will drive home today. I mean, I know it's Oxford, so lots of people will bike, lots of people will run, lots of people will take motorbikes. If you're you may well, despite what Mr. Tebbit says, you may well take the bus. But it's likely, statistically, that at some point you will come across a road traffic collision, someone who's been injured. Most of you have got an NHS car parking sticker in the front of your car. Keep a stethoscope on the front seat. We're all GMC registered, we're all registered with our professional bodies if you're not a doctor. There is an expectation and a responsibility, not necessarily to provide shotgun, heavy, hardcore pre-hospital interventions, but to provide some simple, sensible things that are going to stop the situation getting worse, provide a bit of leadership, and hand the patient over to the professionals when they arrive. And I think that's a responsibility we all have to make sure we can do that. Our aim, as I said at the start, is it's all about rehabilitation. But that rehabilitation is not something that happens in the back end of the hospital after all the sexy stuff has been done. Rehabilitation starts right at the time of the accident, and everything we do is about making sure that rehab happens. So, that's me, okay? Thank you very much for your attention.